Class, I wanted to kind of touch over these different types of adventitious breath sounds that you will be assessing for. Now, as you practice these in lab this week, you probably won't be hearing any of these with your lab partner, but these will be some common adventitious breath sounds that you may hear on a patient. And it's a good thing to identify them as such, but then you have to take it a step further and think to yourself, what does this signify in regards to my patient's respiratory status? What's going on with my patient when I hear stridor? What's going on with my patient when I hear crackles? So I want to kind of go over these and talk about each one and kind of give you the information about each one of these that your book presents as well. The word adventitious. These are breath sounds that are abnormal breath sounds that may be heard on lung auscultation. And here are some examples of such. Now the first one is stridor. Stridor is a high-pitched sound that kind of happens within the trachea and the larynx that really suggests that there's something really serious going on. And stridor could get to the point where it really is an emergency because there really is a narrowing of the tracheal airway, of the tracheal passage. When you ever hear stridor, you'll know it. It's kind of a very scary, almost a squeaky sound. It sounds kind of like that kind of a sound, which really puts your patients in quite a lot of serious distress. Stridor can be heard many times when, for instance, a patient might be have an obstruction. It could be the fact that the patient has a serious inflammatory and infectious process occurring. So those might be examples of why a patient might get stridor. But it really is one of those kinds of sound that's almost like heart-wrenching, and that when you hear it, you never forget it. Kids get stridor a lot with some of the epiglottitis and things like that. But it's something that really will definitely get your attention. It is something that you were not going to need a stethoscope many times to hear. You'll be able to hear it right at the bedside of a patient without even auscultating their lungs. But it could really be a type of emergent situation that you want to definitely do something for your patient right away. This may be a patient who might need an emergency breathing treatment, and it can get so bad that sometimes these patients might need an emergency tracheotomy. The next one is crackles. Crackles is another one of those high-pitched, it's almost like a popping sound, much like when milk pours over like Rice Krispies. Many times you hear them on inspiration. And what is important to know about crackles, it really has to do about fluid. That's usually associated with or resulting from inflammation or exudates within the lung fields, or even a localized atelectasis. This is another serious situation. Usually crackles start down at the bases, and if they get worse, they continue to transcend upward. If you hear them in the bases and then you start hearing them kind of in the mid-lobes, you can see that the patient is starting to really deteriorate. This may cause your patient to have changes in his respiratory rate. He may have more dyspnea. Patient's color may start to change. And this is something that you need to do and to intervene quickly. And so sometimes, you can take it a little further and they might say like there's fine crackles or coarse crackles. But the fact is the patient has some kind of fluid. Could be a patient that has like pneumonia. Could be a patient that has congestive heart failure. but there definitely is a fluid problem. Patient may need some kind of diuretics or that kind of a treatment for it. When we talk about atelectasis, that's really, as I said before, atelectasis is the term that describes a collapse of all or part of a lung affecting the exchange of oxygen and carbon dioxide. Obstruction is one of the primary causes of atelectasis, and this could be due to the fact that a patient might have a lot of sputum and they're unable to cough it up, and we see this in a lot of our patients that have respiratory infections, or even some of our chronic COPDers that have had emphysema for quite a few years. They're just unable to cough up those secretions, and those particular areas of the lung are not having an influx of air coming through it, which it's kind of the old cliche, what you don't use, you lose, and so the lung begins to collapse. And so many of those types of obstructive atelectasis include mucus plugs. It can be also caused by someone inhaling some kind of foreign object, and also airway stenosis, or when the airways actually start to narrow due to some kind of respiratory disease. Another reason why atelectasis begins to occur is because of possible non-obstructive factors. For example, if someone's not really taking in nice deep breaths, maybe post-op, they're very lethargic due to anesthesia, then shallow respirations can lead to the development of non-obstructive atelectasis, where the airways somewhat collapse. This is why post-op, especially if a person has been in surgery a very, very long time, we get that bedside spirometry for the patients so that they can continue to take in those nice deep breaths to prevent the problem of atelectasis. Some of the other conditions with non-obstructive is pneumonia, pneumothorax, and pleural effusion. They also can cause non-obstructive atelectasis. And let me just take a few minutes to talk somewhat about pneumothorax. With a pneumothorax, under normal conditions, when a lung is healthy, normal lung inflation occurs as a result of vacuum effect. It's kind of that negative pressure within the lung, so that causes the lung to expand during inspiration and creates like a negative pressure inside that pleural space, which causes the lungs to actually expand. So sometimes there can be air entry into the pleural space, either through an opening in the chest wall or by way of an opening in the lung, and so it causes a loss of that negative pressure. And this just goes back to basic A&P, why our lungs expand under normal conditions. So with that air going into that pleural space, the pressure between the pleural space and the outside of the body is equalized, and that leads to that loss of vacuum. And so what happens is then the lung actually collapses. And this is what we refer to as a pneumothorax. So please read this section in your book again if that doesn't make sense. It's really a problem with how the normal anatomy and physiology of why our lungs continue to expand and don't collapse. And this could be due to a disease process. Sometimes patients might be involved in some type of injury causing a pneumothorax to occur due to some kind of trauma. And it really depends on how much of the lung has collapsed. It could be just one lobe, it could be two lobes, it could be the whole lung. And obviously the degree of how big that pneumothorax is will really present how your patient exhibits his type of respiratory distress. And signs of someone that might have a pneumothorax is obviously you're not going to hear breath sounds on that particular area of the lung that has the pneumothorax in it. You're not going to see chest expansion. Patient may have pleuritic pain, and it can worsen by movement such as breathing and coughing. Definitely cannot hear any breath sounds over the affected area, and patients will be definitely dyspneic, and that degree of dyspnea will depend on how big of an area is affected by the pneumothorax. And if it's a whole lung, the patient may have really compromised color, meaning that they're very, very cyanotic. A pneumothorax that occurs without any identifiable cause is called like a spontaneous pneumothorax. And some of the reasons why these things occur, and I'm not going to get into the real specific etiology of why they occur, but many times we see patients that have emphysema, cystic fibrosis, and even TB. And then we have a specific type of pneumothorax called a tension pneumothorax, and this results from a traumatic injury such as a lung puncture caused by a fractured rib, or say for instance somebody gets shot in the chest and it penetrates the lung and causes the lung to collapse, causing a person to develop a tension pneumothorax. And this occurs when the increasing intrapleural pressure causes compression and shifting of structures inside the mediastinum, such as the heart and the trachea. And with a tension pneumothorax, we've got to get that air out because it's just expanding in there and causing things to move like a tracheal shift or whatever. And so it is life-threatening, and so it requires a physician or someone with the expertise to decompress either through a needle or putting in a chest tube. Okay, so that's where that's kind of what a pneumothorax is all about. All right, so I just wanted to kind of go over that since we were talking about crackles and atelectasis. The next adventitious breath sound on this list is a rhonchi. All right, and rhonchis are indicate that the bronchioles are occluded, or there is some type of blockage with airway going through them, and usually this is due to possibly sputum. So many times when patients have rhonchi, what we encourage them to do is to take a nice deep breath and give a good cough. And many times the rhonchi will either become lessened or actually go away once the airway has been cleared with that particular coughing. Wheezing is something I'm sure we all can probably have heard in some time. It's a high pitch, just almost sounds like a whistle. Most often heard on expiration and caused by narrowing of the bronchi, but they can also be heard on inspiration as well. And these do not these do not disappear after coughing, because what's happening is the bronchioles are so big, and many times during, for example, an asthmatic attack, because of the response to whatever causes the attack to occur, causes a bronchial constriction, inflammation, hyperresponsiveness. So those bronchioles now, where there was a fairly good sized lumen, now becomes very narrow, and the wheezing is the result of that air trying to pass through a very, very tiny lumen. So that's what we mean by wheezing. And you know, you hear it like just almost like a whistle. The last one here on this list is a pleural friction rub, and this is associated with pleural inflammation. It occurs when the inflamed pleural surfaces slide across one another. It's almost like a rub or like a crack, and it can happen both during inspiration and expiration. So these are the main type of adventitious breath sounds. Remember, adventitious meaning abnormal breath sounds. So I just wanted to go over those with you, since we will be doing breath sounds in lab this week as you learn to auscultate at certain landmarks anteriorly and posteriorly with your lab partner this week, okay? All right, so I want to continue with diagnostics. Now, this wasn't actually on your actual reading, and the reason I didn't have you read this because I was concerned that students would ask, do we have to know all the specific lab values or lab tests that go with pulmonary functions? And of course the answer is no. I just want to pick out some ones that you should know at this stage as you begin nursing school, and which ones you may see your patients have at the bedside, or something that you may be able to initiate or suggest to the physician that the patient have. So first of all, a sputum specimen is something that is very easy to obtain. When you really feel that your patients really have a lot of sputum, and maybe the patient spikes a fever, it's just a good idea to get a sputum specimen, because let's take that specimen down to the lab and analyze it and see if the patient is harboring some kind of organism that's causing him to maybe develop a respiratory infection, and then we'll be able to treat it with the right medication, such as an antibiotic. This is a real easy order to get. Go ahead and get the specimen, and the physician will be able to give you the order to say to obtain a sputum specimen for CNS, which means culture and sensitivity. They'll culture it, and then they'll put various antibiotics on it to see which one the pathogen is sensitive to, and that's what will be ordered for the patient to hopefully rid himself of that particular organism in his sputum. The next one is arterial blood gases, and this is a great indication, and it's a great lab value that really helps us to understand what's going on with your patient. I'm not going to get into this now, but I just want you to be aware that many times when our patients are developing some respiratory distress, you're concerned about his breath sounds. Maybe in the morning he was clear, but now you're hearing some of these adventitious breath sounds. Patient's really feeling lousy, becoming more dyspneic. Color doesn't look as good as it did this morning. This will definitely be ordered. We can really look at our patient's pH and all the other components of the arterial blood gas studies. But right now we're not going to really go into detail about this, because we will be talking about these in 8B. Okay, so I just want you to understand that if you think that your patient is doing poorly in regards to his respiratory status, then this is a very easy order to get as well. You can get the house doctor or the hospitalist or someone, even the nurse practitioner, to order these for the patient. It is something that you will not be doing, but can be done by a respiratory therapist. And like I said, I'm not going to get into a lot of detail, but I just wanted to give you this diagnostic as just a familiarity right now, and then in 8B we'll go into it a lot more in detail. Okay. Pulse ox is something that we do on all our patients when we do their blood pressure and their pulse and their heart rate, their pulse and their respirations. This is a simple machine that is non-invasive. They just put it on the end of a person's finger, and it really does assess arterial blood oxygenation. It's just like a little clip that has an infrared probe that analyzes blood as it perfuses past the view of the two opposing sensors of the probe. Unexpected SaO2 value in a healthy individual, one who has no alterations in pulmonary functions, are usually greater than 95%. If you happen to get a abnormal reading, always make sure that the machine is functioning well, because if you get, for instance, a reading of 89% and you're looking at your patient and they're pink and they're doing well, it may be that the machine hasn't been calibrated in a while. Maybe that the patient, or especially if it's a female, has any acrylic fingernails. All those types of things will affect the reading, because remember, it senses that O2 level by these infrared probes. So if anything is blocking that, or is a barrier, or the patient's not perfusing well, then this will definitely result in maybe a weird reading, okay? So I just want you to know that. The next set of diagnostics are pulmonary function tests, and we call those those PFTs. And these are a very, very, I would say detailed description of a person's really complete lung function. It demonstrates changes in pulmonary health related to ventilation, airflow, lung volume, capacity, and definitely the diffusion of gases. They also incorporate a lot of other things like spirometry, peak flow meters, and inspired and expired air. I don't expect you to know all these in detail. I don't know them all in detail. I do know that these are ways in which we can diagnose some certain chronic diseases such as asthma. We might be doing a pulmonary function test on somebody to clear them before they go to surgery, because like I said, it gives us a very detailed description of really what exactly is their very detailed lung function, okay? But your book does talk about all the various testing that's involved with pulmonary functions. Usually the patients leave the floor. They go to somewhere maybe down in X-ray, and these are done by people with a lot of experience and expertise, because these can be very long and time-consuming and can be very exhausting for the patients, because they have to do a lot of deep breathing and holding their breath and things like that. So sometimes patients get too exhausted and they don't even get through all the procedures, but hopefully they got through most of it so they can get a pretty good idea of the exact lung function of that individual. So that's pulmonary functions. And like I said, I would never expect you to know all the detailed testing that goes with those particular diagnostics. The next one is a chest x-ray. This is something that you need to think about, because all patients that are admitted to an acute care facility will have a chest x-ray, and there's so much we can learn from our patient's chest x-ray. It's a two-dimensional visualization of the contents of the thoracic cavity, and our chest x-ray can make very definite diagnoses. Patients come in with some kind of respiratory problems, not sure what's going on, they're going to do a chest x-ray. It reveals the presence of fluid, exudates, masses, and many times those would warrant the patient to having further testing done, such as a CT of the chest or a MRI, okay? It also is good to look at structures in the chest cavity. It gives like a crude type of image where you can't see a lot of definition, but obviously you can look at ribs and look at structures, look at the size of the heart, the cardiac silhouette. It can diagnose a pneumothorax after a patient has a chest tube put in. Another chest x-ray will be done to verify placement and re-expansion of the lung. We can diagnose pneumonia, pleural effusion, atelectasis. Another reason that we might use a chest x-ray is for proper placement of central lines. For instance, if our patients need one because they are getting very multiple medications, they might put a central line in. If the patient is having cardiac and respiratory problems, they put in a Swan-Ganz catheter, and you all want to make sure that those are in the correct place before they're used to infuse IV fluids or blood or whatever. They're also used for placements of PICC lines, and another thing that we always do with a chest x-ray is look at where patients are just newly intubated, to make sure that the endotube is in the correct position, that it's ventilating the patient properly. So these are all the important reasons why chest x-rays are done. Many times when patients come in with respiratory issues, they might have a chest x-ray done every day times 3 days. And what we do is compare that chest x-ray of a particular day with the chest x-ray of the day before to see if the patient's condition is improving, the lungs look clearer, the atelectasis is better, less fluid, whatever the primary diagnosis was, is it getting better? And that's what our chest x-ray can do for us, to let us learn a little bit more about our patients, and possibly, like I said, might provide us with some information but not enough to make a definite diagnosis. So a CT might be done, or even a pulmonary angiogram or a pulmonary VQ scan. Say if it suggests that the patient might be having some structural changes or pulmonary vascular changes, such as maybe now the patient is thought to have a pulmonary emboli. These are kind of the additional studies they may do on the patient to make that diagnosis. And so I just wanted to kind of let you know that, okay? Talked about pulmonary angiograms, talked about pulmonary VQ scans, because with that one particularly, they do use radioactive isotopes to identify defects of ventilation and perfusion. And like I said, that might be due to something like a pulmonary infarct or a patient having possible pulmonary emboli. Okay, and then the next one is a bronchoscopy. Okay, and think about bronch. They're going to take a scope or a tube and gives the physician a direct visualization of the lungs. It's usually performed by a respiratory type of pulmonologist, but it can also be done by an internist or possibly an emergent care physician. And the bronchoscope is inserted into the trachea and kind of advanced downward to look at all the structures. There's many reasons why we do bronchs. Could be for just to look down at the structures, to see exactly what they look like. If there's any tumor, might do a biopsy, can do a bronchoscopy to instill medications to kind of open up that area. Might want to do a bronch to suction out if the patients have copious amounts of thick secretions. They definitely might want to take biopsies and specimens. Now think about it, when you're putting a tube down into the trachea, the patient has to be sedated, because obviously with a cough reflex, the patient would not be able to tolerate that, which would make sense. So they're going to be heavily sedated. So when they return to the floor, it's really important that we don't feed them, either drink or with food, until we know that that cough reflex and gag reflex has come back. So those are what you would want to assess. Patients may be very dry when they come back, so before you give them any sips of water after bronchoscopy, you want to make sure that they're doing okay, that there's not an unusual bleeding, that the patient isn't developed some kind of infection, because all this should be done under sterile technique, and that the patient does have his gag reflex returned before we give him any sips of water. Okay, and lastly on this slide is the thoracentesis, and this is just a way in which we can maybe remove fluid out of that pleural space. Remember, I talked about earlier the normal anatomy and physiology between the viscera and the parietal layers. When too much fluid gets in there, we might have to have it removed, and there's many reasons why that happens. Could be due to just infection, could be due to some type of cancer, but whatever the reason is, the fluid is impeding their inhalation as well as exhalation. So we may get in there for a chance to remove that fluid, or maybe we're getting in there to do some kind of diagnostic testing. It's helps to drain those excessive pleural fluid from between the pleural linings, and then Obviously, the patient will be anesthetized at the site, just a local. Patient has to be awake. Can do this at the bedside. I've done it at the bedside many times. Have the patient lean over on the bedside table. You as the nurse are present just for moral support and obviously to watch the patient to be sure that the patient is tolerating this procedure okay. Sometimes when it's hard to know if the physician is getting into the right space, they might do it under what we call fluoroscopy, where they can actually take a picture of the area and know right where they're going, so there's no chance of hitting the lung and causing the patient to develop like a pneumothorax. Obviously, once the procedure is complete, that fluid that's drained off from the pleural space will be analyzed for blood, fiber, and microbe content. And you want to definitely document how the patient did through the procedure, exactly how much was taken off the patient, and how well the patient tolerated the procedure. So that's kind of the documentation that you'll follow when the procedure is completed. Now, patients usually do fine from a thoracentesis, but because it is an invasive procedure, or things that can happen where if the patient's going to develop a pneumothorax, it's going to happen usually within the first 24 hours. But again, observing the patient, making sure there's no respiratory issues, making sure he's not developing some kind of an infection, and then definitely being on the alert to what those test results come back as can really tell us a lot about our patient. So that's pretty much the diagnostics that I think it's important that you know. And then, of course, we look at independent interventions. These are things that we might, as nurses, do with our patients to definitely improve gas exchange and really to enhance breathing patterns, especially if they're showing signs of, poor inhalation, or maybe the patient has been just had surgery and on their abdomen, and maybe they're not really taking in nice deep breaths. These are kind of things that we would intervene with to ensure that our patients are definitely being oxygenated to the best of their ability. And first of all, deep breathing exercises, okay? Because many times it might be just as simple as doing a deep breathing exercise. Maybe the patient's been lying in bed, not moving around a lot. Maybe he just had some kind of surgery, and maybe he's in some pain. So besides giving him pain medication, we also want to make sure that he is maintaining a good pulmonary hygiene, okay? Because doing these kinds of things with our patients really promote good gas exchange and prevent complications from happening down the road, all right? So maybe you might notice that the patient is really developing a little more dyspnea. Maybe they've developed a fever, and maybe they're just not having the energy to cough up the secretions that they have in their lungs due to the fact that, they had some type of surgery. Well, things that may alert you to that would be maybe their heart rate's gone up, their respiratory rate's gone up, and maybe their color just isn't as good as it used to be. So one thing that we can do is to continue to encourage our patients to do deep breathing exercises. And these exercises work on the body's sympathetic nervous system to influence the body's respiratory system. So some of the specifics of deep breathing exercises are known as diaphragmatic or abdominal breathing. And so what we encourage our patients to do is use their diaphragm to force it up and down to force it down when it contracts, which in turn causes the abdomen to expand. So this negative pressure, that this particular type of exercise causes will force more air into the lungs while also pulling blood into the chest, thereby improving venous return to the heart. So I think people don't realize how important something as simple as just a deep breathing exercise can do for our patient. And you can show the patient how to do it according to your book, how we perform it with in 2 steps, okay? Another thing that we do with our patients is proper positioning. Positioning does affect oxygenation. Fowler's position may be beneficial to some individuals experiencing some alteration in their oxygen, and your book does give a picture of Fowler's, which is, let me think, Fowler's position is about 45 to 60 degrees. When we talk about semi-Fowler's, that's about 30 to 45 degrees, and a high Fowler's position is usually about 80 to 90 degrees. And just positioning our patient can help them to maybe cough and deep breathe better and to better oxygenate, okay? Obviously, if there's any type of respiratory problems, it's always encouraged to, tell our patients to definitely quit smoking, which we don't want to, be preaching to the patient, but obviously smoking would be the worst thing that they can do. And your book does talk a little bit about smoking cessation, and it's on page 1029. And I'm not going to go into that because I think we know the horrid effects that smoking does to the respiratory system. It increases mucus production. It destroys the cilia. That's a great way to push away a lot of the bacteria or any kind of foreign body that gets into the lungs. So, plus it does a lot of havoc to the cardiovascular system, causing a lot of vasoconstriction. So, provide the tools to help our patients quit if that's what they choose to do. You may not be able to, but it may delay their healing and recovery if they continue to smoke, okay? Especially if they're coughing a lot, gives them more of a chance to acquire some type of respiratory infection, all right? The next one is monitoring activity tolerance. Obviously, as patients begin to get better and heal, we know that how they are presented with their respiratory system can affect their activity levels. Having a major respiratory illness or recovering from some type of surgery, everyone will have some sort of energy level at that point, and sometimes depending on that energy level, it's really difficult to get up and start walking and feeling yourself again. People that are poorly oxygenated have a lot of fatigue, a lot of weakness. Maybe they're just being worn out because they've had a lot of diagnostics and we're not really spacing that activity and our plan of care very well, and we're just really tiring out our patients too much. We're going to see probably some dyspnea or shortness of breath, but it can definitely happen at varying points in the exercise program. Some of our patients may be too weak to provide their own care and may need assistance with just helping them with their bath, washing their feet and their legs, just to the nature of their disease, which could be at end stage, and maybe that's as best as they're able to do. So we have to definitely assess our patients in that way to know when it's necessary that we intervene and help them with a lot of their EDLs. Patients that just don't have the energy to bring up sputum, maybe they might need assistance from the respiratory therapist, maybe they need treatments, maybe they need help with, trying to bring up those secretions. And that brings us next to suctioning. Sometimes we might have to suction our patients. A lot of times we do orally when those secretions are in their oral cavity, or there are times where we might have to go down into the lungs with a suction catheter, making it a sterile procedure to try to help them assist with expectorating those mucus. You got to be really careful though. It should only be done by someone who is an expert. The nurse should decide when suctioning is needed by assessing the patient for signs of any type of distress, dyspnea, bubbling or rattling breath sounds, poor skin color may indicate the need for suctioning. Don't forget, it can help, but remember, suctioning can be very irritating to the mucous membranes, and it can also increase secretions if performed too much. Remember, suctioning is based on clinical need, not on a fixed schedule. So we might do more oral and oropharyngeal suctioning to remove secretions from the upper respiratory tract. Many times if a patient has a tracheostomy or an endotube, we have an easier access to get down there in the lungs than we would under normal conditions. But it is a nursing judgment. You don't need an order for it, but you have to be very careful because it is a very traumatic type of intervention, especially if our patients are conscious and wide awake. Nobody likes having some type of catheter put down in our lungs because it can be very, I'd say painful to a point, but it's very scary for the patient because they feel like they're suffocating, and that would make sense when you think about this catheter coming down into the lungs or into the trachea. Make sure you're observing the patient and you do it in the correct way, because you could set off a lot of problems down the way, causing patients to develop arrhythmias and things like that. So, only do it for a few seconds and only put suction on as you come out. So these are the kind of guidelines that should be followed when you're trying to do suctioning. But really, it should only be done by someone who has experience in doing it, okay? Because not only are you suctioning out secretions, but you're also suctioning out oxygen. So you do deplete your patient's oxygen levels as well. Assisting with activities of daily living, I've kind of hit upon that somewhat, knowing which patients need what, and are these patients able to care for themselves when they go home. Those are things that you want to also think about as well. And nutritional management is very important. Remember, when patients do have a lot of respiratory distress, it really requires more calories. Maybe a dietitian or a nutritionist can help the patient to select foods and supplements to meet that daily caloric and nutritional need. And helping the patient or the wife or whoever is in charge of grocery shopping and cooking to help develop menus that are simple, but also provide those necessary things as well. I'm not going to get into the pharmacological therapy. That's not what we're going to talk about right now, so you don't have to know anything about medications. This isn't a pharmacology class, but many times you should know that patients will be on certain medications to help them, especially ones that have chronic problems such as asthma, emphysema, and things like that. So we won't get into that today. But I did talk earlier about incentive spirometry, and this is something that is very useful for our patients. It's a breathing exercise that we keep just at the bedside to help patients breathe deeply to expand their lungs. Usually there's a little arrow that points to what we would hope that the patients can aim for as to how high they can get that little bubble as they take in that nice deep breath. And this helps patients to clear a lot of their mucus and secretions, and It's very commonly ordered for patients who are post-op or patients who are laying in bed and immobile. And the important thing is that a patient is given a demonstration on how to use it effectively, and that the patient is using it at least every hour. Okay, because it won't help him at all if it's just sitting there on the bedside doing nothing. Very frequently, if not all the time, patients who do have respiratory alterations will be on some type of oxygen. I'm not going to get into a real lot of detail, but I think it's important that you as the nurse know if the patient should be on oxygen, and that to be sure that the patient is, and that he's on the correct amount of percentage of oxygen that's been ordered, and that he's having his oxygen delivered through a system that has been ordered, whether or not it's a nasal cannula, a simple mask, a Venturi mask. And we'll talk about all those in 8B. I'm not going to get into the different types of oxygen modalities, so we're not going to even talk about that. I'm not going to get into chest tube management either. We just know that many times these are used as a means to expand the lung if a patient would develop a pneumothorax. But as far as specifics about chest tube management, you're not responsible to know that. You'll get that later on. And these are just lifespan considerations, which I think is important to know. You know, we're going to do some exercises that definitely show the differences in anatomic differences between infants and children, and how they differ from adults. Okay, and it kind of explains many times why kids have more respiratory infections than adults do, just by the anatomy that they have. Okay. And infants and children, their secondhand smoke is something that we need to think about, and it causes lungs to develop more slowly. They have more of an increase of respiratory infections, can trigger asthma, and it can increase incidence of wheezing, coughing. So we encourage the parents to quit smoking, and encourage influenza immunizations, which this time of the year is when we should be seeing kids as well as adults get those flu shots. And then this just talks about pregnant women, avoid positioning that may be harmful to the fetus. That might be prolonged supine positioning. Anytime there is some type of compromise in oxygen levels, treatment should always involve both pulmonologist and obstetrician, because we're not dealing with just the patient, but also with the unborn child. Anytime any medications are given, to see that to be sure that it's safe for the unborn child. And then again, some of the unfortunate things that occur with the older adult. Expect decreased breath sounds, inspiratory crackles common. Just how the body changes over time. Assessing for kyphosis, children with scoliosis. Vesicular breath sounds with longer inspiratory phase might reflect respiratory alterations, especially if the patients have been diagnosed over the years with COPD or asthma. And then we're not even going to talk about pneumonia this time. That will be one of our exemplars in 8B. And these are other considerations with the older adult, and we've kind of touched upon these quite often in the last 4 weeks when talking about this age group. Changes in medication, changes in fluid and nutritional status, changes in cognition. Sometimes older patients who are too ill to sit up may have artifacts on examination due to positioning. If our patients do have a lot of secretions, these are things that we can use as far as treatments to help bring up some of those secretions, okay? And that pretty much concludes the reading from your concepts book. I hope you find it helpful. You also had some assigned reading in your Barbarita. We'll just kind of glance over that and be sure that there's no questions, but a lot of the things in your Barbarita kind of has overlapped in some of the things that we've already discussed here from your concepts book. As you go through your D'Amico and Barbarita book, your reading starts on page 298. Really talks about some of the things we've already talked about. The respiratory process, thinking about what muscles are involved in respiration, the thoracic cage, some of the terms that I've already gone with. It's really important that you look at the section on landmarks, okay? Because those are the landmarks that you'll be using this week when you go to assess your lab partner in regards to his breath sounds, to auscultate his chest anteriorly and posteriorly, okay? Some of the areas that you can see as you look at the gentleman here on page 300, and it's a great idea to even just take the skeleton that's in the lab to look at your landmarks when you kind of are able to see the ribs, and to kind of know where some of these landmarks are, especially when we do perfusion on Wednesday. But we'll be auscultating 8 landmarks on the anterior portion of the chest and 10 landmarks on the posterior, okay? And like I said, you're going to get your sheet, if it isn't already included in your packet for lab, about where that stethoscope should be placed, okay? This reading takes you all the way to 329, and it's just a section that kind of talks to you about how to interview a patient for certain things and what kind of equipment you might need to obtain, some of the objective data in regards to your patient's respiratory status. And then if you look on page 314, I think these abnormal chest configurations are important to understand, because especially from your particular population of patients, you're going to see maybe some of them have that barrel chest, and exactly what is that barrel chest and what causes that barrel chest and how that reflects his respiratory status at that point. Some of the other things that we see is scoliosis, that it can impair respiratory function, as well as some of the problems we see with our patient's spine. The elderly woman right here that is presented in a kyphosis stage, where there's that exaggerated posterior curvature of the thoracic spine, which definitely will affect inspiration, okay? Another thing that you might hear the term fremitus. Fremitus is that palpable vibration on the chest wall when the patient speaks, and it's pretty much strongest over the trachea, and it diminishes over the bronchi and becomes almost non-existent over the alveoli of the lung. And there are certain conditions or certain alterations in respirations that increase or decrease fremitus, and that's when we look at fremitus to see if it's a significant finding, okay? Decreased or absent fremitus may result from a soft voice, from a very thick chest wall, from obesity, or from some of the underlying diseases that are probably more common to you, which might be COPD, pleural effusion, and increased fremitus occurs with fluid in the lungs, fibrosis, tumor, or infection. So if someone has pneumonia, you're going to definitely assess increased fremitus with that patient. So that's important to know, because we're going to do this case study together on this gentleman who has chronic obstructive pulmonary disease, and there is a question about fremitus. So I just wanted to bring that to your attention. And then Again, it talks about auscultating lung sounds, and again on page 319 there's a table that again discusses adventitious breath sounds, rales, fine or coarse, rhonchi, wheezes, stridor, and friction rub. Again, things that I've already talked with you about. We will not be doing any palpitation. We're just doing, yes, we will not be doing any palpitation with the chest. We'll only be doing auscultation with the chest, okay? So you won't be doing any types of assessment for fremitus. But earlier in this lecture, I talked about ventitious breath sounds, and there's a nice picture on page 322 that has where you would hear those normal breath sounds or vestigious breath sounds when we talked about tracheal, vesicular, and bronchovesicular, where exactly those are at. And I think that's a nice diagram that kind of explains that if you didn't quite understand what I was talking about. Another thing I wanted to show you too, there's examples too of atelectasis that I talked about, and that's the one that really you have to know at this point, because the other ones are more exemplars that kind of show you a particular respiratory disease. Pleural effusion is another one that you may want to look at, because you might find that as a reading on a chest x-ray, or even our patients that have pneumonia. There's a nice picture of what a pneumothorax would look like, and that's on page 328. So this concludes pretty much this overall discussion of the information in your book, what important terms, but how we relate that to our patients and how important that is to us as nurses. And then on the next one, on the next lecture, I'm just going to go over the case study with our gentleman who has COPD. If at any time you want to ask me questions, feel free to ask me questions. This lecture will probably be a little bit over 2 hours, because I do want to go over the case study with you, but at least you have this PowerPoint and my discussion about some of the things that I find important that really you need to reread and go over and understand if you're not quite sure what that problem is, or why we do the interventions that we do for our patients, or why we assess them. And when you do find that assessment, what does that mean in regards to your patient? So please ask me any questions you may want. So this definitely concludes this lecture. Thank you.